I'd like to welcome you all to the second of our 2017 collaborative webinar series. Thank you for joining us today. My name is April Latson, and I am the Community-Based Organization Outreach Coordinator for the SiNERGe project representing the William E. Proudford Sickle Cell Fund, and I will be your moderator. With these presentations, we are hoping to provide the most current information on a variety of topics of particular interest to the sickle cell community. These webinars are open to all interested parties, and we welcome your input regarding any topics that you would like to see covered. At the end of the presentation, I will be reading questions from the audience. Feel free to post your questions in the group chat box on your webinar page, or if you are joining us by phone, please feel free to email your questions to me at alatson@wepsicklecell.org. Again, that's ALATSON@WEPSICKLECELL.org. Today, we will be exploring information on chronic opioid therapy and sickle cell disease. Our presenter today is Dr. C. Patrick Carroll, Director of Psychiatric Services to the Sickle Cell Center for Adults, Service Line Director of the Intensive Treatment Unit, Assistant Professor of Psychiatry and Behavioral Sciences. I'm sorry. Something just happened here. I'm sorry, give me 1 second. Okay. Again, our presenter today is Dr. C. Patrick Carroll, Director of Psychiatric Services to the Sickle Cell Center for Adults, Service Line Director of Intensive Treatment Unit, Assistant Professor of Psychiatry and Behavioral Sciences at the Johns Hopkins School of Medicine. The views expressed by presenters are their own and do not necessarily reflect those views or opinions of William E. Proudford Sickle Cell Fund, the SiNERGe project, or associated parties. This webinar is for informational purposes only. Individuals seeking medical advice should always see a qualified health professional. Presenters will share professional insights, accounts, and experiences regarding chronic opioid therapy and sickle cell disease. Today's speaker, Dr. C. Patrick Carroll, is an internationally recognized expert in the multidisciplinary management of complex and high-utilizing patients with sickle cell disease. After completing his graduate medical training at Washington University in St. Louis, he completed residency in the Department of Psychiatry and Behavioral Sciences. Thereafter, he was a fellow in the Behavioral Pharmacology Research Unit, studying the behavioral pharmacology of opioids. Upon leaving the fellowship, he joined faculty as an Associate Medical Director of Addiction Treatment Services, a leading addiction treatment center at Johns Hopkins Bayview Medical Center. In 2007, he assumed his current role in the Sickle Cell Center for Adults, combining his interest in chronic pain, opioid pharmacology, and the care of complex patients. He attends in the Department of Psychiatry's Pain Treatment Program, an intensive multidisciplinary treatment program for patients with refractory chronic pain or abnormal illness behavior. Recently, he assumed the role of Service Line Director for the Intensive Treatment Unit, an inpatient addiction treatment unit with which he has long association. He has published a number of peer-reviewed papers on sickle cell disease pain and treatment utilization. In addition to his earlier work in behavioral pharmacology and addiction treatment, along with the multidisciplinary team of Johns Hopkins Sickle Cell Center for Adults, he has been consulted regionally and internationally regarding the management of chronic pain, psychiatric illness, and the treatment utilization in sickle cell disease. I now invite Dr. Carroll to join us and talk to us about chronic opioid therapy in relationship to sickle cell disease. Dr. Carroll?
Hi, everybody. Thanks, April. Wow, you sound made me sound better than I am. Let me see if I've got control of this thing before we go on. Yes, looks like I do. Okay. Hello, everyone. Thanks for inviting me. I'm glad everybody's here. Whoop, I think I just had another lag. So I'm going to talk about some of the complexities of trying to think about who should be on opioids for chronic pain with sickle cell disease, and some of the complexity from a kind of a doctor's perspective as to how to make that decision, how to try to keep people safe when you are making that decision, and when to decide that it's gone wrong. Just by way of, sorry, I'm still learning to operate these controls. Just by way of introduction, I don't think that this is going to be a surprise to anyone who's listening to this right now. But if you were to look at the literature on sickle cell disease, maybe 20 years ago, you would probably get the idea that people with sickle cell disease were doing perfectly fine, then would have an episode of severe acute pain and then would immediately go into the hospital. Crisis was basically the same thing as hospitalization. And those two things were basically the same thing as pain. And I think it's clear to anyone who's an adult living with sickle cell disease, I think that that's not true. But I think it was relatively slow to dawn on the medical community, quite frankly, that that's how things are. This is a slide taken from the Pisces study, which was a very important study of the pain experience of adults with sickle cell disease. And mostly I just want to point out the last couple of lines on that table, which is that a solid majority of people with sickle cell disease have pain most days, and probably about 30% of people or adults with sickle cell disease have pain just about every day of their lives. And the pain, people who have more pain daily also seem to have more crises, and their crisis pain tends to be worse. So it all goes together. This is another slide from the Pisces study, and the thing I want to point out are that top little sliver there, that little white thing that says 3.5%. That's the time that people in the study were in the hospital in some way, in an emergency room, inpatient. Just under that, the one that says 12.7%, the one that's about 3 or 4 times as large, is the number of days that people spent in crisis but not in the hospital. So crisis and hospitalization obviously are not the same thing. And then right under that, where it says 38.3%, those are the days people had significant amounts of pain but were not in crisis. So crisis is certainly not the same thing as hospitalization, and pain is certainly not the same thing as crisis. And so when you're looking at, say, hospitalizations as a measure of the pain experience of people with sickle cell disease, you're really seeing the tip of a very, very deep iceberg. And a large proportion of this pain that folks experience is not defined by patients themselves as crisis, and often is quite chronic. So we want to talk about, particularly, there's a lot of things you can do for chronic pain, but we're here to talk about opioids. And I thought just to start off, I would give an idea about how I personally, as a physician, make decisions about almost anything I do. And I'm notoriously simple-minded, but I pretty much live my mental life in this little 3x3 box. And whenever I'm trying to decide whether to start any kind of treatment for anyone, I usually am thinking on 2 dimensions. One is, what's it going to do for the thing I'm trying to treat, in this case, pain? And, it's either going to make it better, do nothing, or make it worse. And then every medicine has some other kind of effect. And usually their side effects are undesirable. Every once in a while you get a side effect that is desirable, but pretty much never happens. And so even within this little box, you can usually narrow it down to it's either going to make the thing you're trying to treat better or not work, and it's going to have some level of side effect. And so I'm always trying to figure out if what's the chance when I'm starting something, what's the chance that it's going to make the thing we're trying to treat better? And what's the chance that it's going to have some significant effects that are going to bounce that out and make it not worth it? Now, if the thing has very little chance of working, but has a solid chance of causing problems, there's no point trying it. Or if it turns out that when you start it, it has a significant set of problems and doesn't particularly work, then you don't keep going. And so this is kind of the way that I think most physicians tend to think in terms of how to start things. And then as you are managing as it goes along, you get to see if the way you and your patient place the bet turns out right. You get to see if those side effects are actually going to happen and if they're going to be significant or not. And you get to see whether your bet that this is going to make people better actually pays off. And then you can decide whether to keep doing it. Now, this is a general way of thinking about things, and I think it's kind of, it's a simple and straightforward way of thinking about things. But as is true in almost everything, the devil's in the details. And this is true of everything. But with opioids, there are some specific complexities about it that make figuring out what to do, especially over the long term, pretty complicated. When you're dealing with acute pain, something that you know is going to have a beginning, a middle, and an end, and there's a period of time where people can be on the opioids and a period when they can come off of the opioids, and the chance for long-term trouble is pretty low. In a lot of ways, that's a much simpler thing. In terms of chronic opioid therapy, there's a lot more fog. And there's no need to memorize this outline. I'm going to be returning to it over and over again, but this is just the sort of structure of how I want to talk about this. So one very basic and fundamental problem we've got with chronic opioid therapy is their evidence base for long-term therapy for chronic pain with opioids is pretty poor. In terms of opioid therapy for chronic pain, we have very few trials that are longer than about 12 weeks, and most of them are actually in the range of 6 weeks. This can make a very big difference because there are a number of interventions that we know about that can make people better faster, but don't necessarily get people to a better endpoint if you wait longer. And we've seen this in things like back surgery for sciatica. So longer term follow-up, particularly when you're talking about something that people may need to be on for months and years, is very important, and we really lack it with chronic opioid therapy. We do know, just as in observing nature, that a good number of people who are on opioids for CNCP, means chronic non-cancer pain, not necessarily sickle cell disease, but pain in general, a good number of people will get worse. Whether that is progression of the underlying disease or if it could be some adverse effect of the opioids is hard to tell. Also in these short-term trials, which I said are mostly in the range of 6 weeks, a lot of people wind up just stopping the opioids. About 10% of people seem to get no benefit, and they get no benefit to the point that they're not willing to keep doing it. And then another, say, 15%-ish usually stop because it has some other side effect that they just can't stand, for which constipation tends to be a major player. And then again, over long-term observational studies, these aren't randomized trials, a solid number of people who are placed on opioids will stop them, again, either because of lack of effect. So they certainly don't seem to work miracles for a lot of people. And we don't have any good way right now, when we start out, of knowing who's going to wind up in this 20 to 50% of people who are going to stop the opioids because either they don't work or because they have too many side effects. And so a lot of it is trial and error. Another thing that I think is particularly tricky in chronic pain is that there's lots of different things that you want to see happen for people when you're trying to treat them for chronic pain. And opioids are good at getting some of those things to happen, or reasonably good, and not very good at some others. So in the chronic pain literature and in the chronic pain field, there's a couple of major things I think we tend to focus on. One of them is the pain intensity, which is what happens when doctors ask about, where is this pain on a 0 to 10 scale in terms of how bad it is. That's what we usually call pain intensity. And then with chronic pain, another thing that we know is that people who have chronic pain tend to have a lot of disability, and they tend to have impaired function. They're not able to do as many things as people who don't have the chronic pain do. Now, in terms of pain intensity, that's what is the main endpoint for most studies of chronic pain with opioids. And because it seems like people who say they have about a 2-point reduction out of 10 on their pain intensity say that this was a significant reduction, this made a difference in my life, we usually use a 2-point reduction or a 30% reduction from the baseline pain as a measure of success in a clinical trial. To get that level of success, usually you have to put about 3 people on chronic opioid therapy to get one of them to have that. That's a modest level of success, I think you would say, for a lot of different interventions. But when you look at other outcomes like functional outcomes, they're not nearly as good as reducing the pain intensity. I have a background in behavior, and I think that this makes perfect sense to me in that if you've had someone who's had chronic pain for a very long time, a lot of quality of life and function is about how you act. And as people become more disabled, very often life kind of reorganizes itself around the disability. So if you used to work and you no longer work, even if your pain has been reduced by whatever therapy is being done, that doesn't necessarily mean that the job instantly comes back. Or if your social circle has decreased because you've wound up being stuck in the house a lot more, it doesn't necessarily mean all those friends will come back because your pain has dropped by 2 points. And so there's a whole rehabilitative and rebuilding process that tends to happen to get function to improve that isn't necessarily going to come back just because the pain intensity has improved. So, if you're looking to get people's lives better, reducing intensity is one thing that matters, but there's other things that matter a lot too, and the opioids aren't really probably sufficient to get all that to happen. So if you're defining success by reduction in intensity, opioids look reasonably good. If you're defining success in terms of function, opioids might be part of the solution, but they're probably not the thing. That being said, in terms of that success, but then in failure, there's, as I said, about a 20-25% dropout rate for a lot of clinical trials in opioids. And then in the real world, we have this problem that the opioids don't either give you a 2-point reduction in your pain or nothing. They have all kinds of effects, and sometimes they change over time. And sometimes if someone has a pain reduction from, say, a 7 to a 6, it probably was the opioids that did it. It's probably not that much, but then again, does that mean it was a success or a failure? And then do you stop it or do you keep it going? And there's a gray area there that's hard to make decisions in for both doctors and patients, I think. Now, another thing that I think, in the current environment, I think everyone's probably aware that we're in the midst of an epidemic of problems with opioids. It has been related to prescription pain medicines. And there's a whole set of problems around this. One of them is that the opioids themselves, they just have dangers. And one of them is the respiratory suppression you can get, particularly at higher doses. Another is that they have these behavioral effects. They, it's part of a thing that opioids do, is that they're able to train human beings and other creatures to take more of themselves. And that, when it happens outside of a pain management situation, we use the word addiction for it. I think that may not be the best way to think about it in terms of when it happens in a medical situation, but we have this word. And one of the problems I think we have in the pain field with opioids is that what constitutes addiction versus not addiction is not particularly clear. And I think it might actually, our trying to figure it out often gets in the way of real understanding. So you can see this even in the literature, because if you look back, I don't know, maybe 20 years ago, you would see estimates of opioid addiction in pain populations of a couple of percent. And then you can also quote some papers that will point out prevalences of problematic behaviors in the range of a quarter to a third of patients. And when you have estimates of prevalence of something that vary by a factor of 10, what that probably means is you don't really know what you're looking for. It means you don't have the target condition adequately defined that you can reliably detect it. And when we're talking about addiction in the more traditional sense, the criteria that were used to diagnose addiction themselves are going to be muddy in a population in which opioids are prescribed by doctors or other providers. So one part of those criteria were tolerance and withdrawal, meaning you'd have to take more of the medicine to get the same effect. And if you stopped it, you would have a withdrawal syndrome. If people are prescribed opioids every day for a significant period of time, that's simply going to happen. And it's not evidence that anything problematic is going on. If you got another sort of criterion was people who were using the opioids for addiction should be impaired by the use of the opioids. That's what makes it abnormal. But the difficulty you have in the situation of pain treatment is everybody who's being treated for a painful disorder has a painful disorder, which is going to be impairing. And so if you have a medicine prescribed for something that's impairing and impairment for the thing, the two are hopelessly compounded. And you can't figure out what's what, particularly over the long run. So tolerance and withdrawal are to be expected, and they don't mean anything's bad. Impairment is to be expected to some extent, and it's hopelessly confounded with being prescribed the medicine to treat the impairment. And so then we're left with just what is the person doing? And so there are certainly some behaviors that people can do around opioid prescriptions that are worrisome. If you have someone who keeps saying that they've lost their prescription, or if you go to the extreme, someone who's forged prescriptions or who has tampered with delivery devices for their opioids, you can clearly say that's really concerning. On the other hand, if you have someone who's lost one prescription in the last 25 years, that's not necessarily evidence that anything particularly bad is going on. And so even though you can say this thing happened, these behaviors happened, there's always a number to them and a severity to them. And to some extent, the severity is a value judgment. And so we have a difficulty in the pain field where a lot of the things we rely on to diagnose addiction outside of the pain field are just not helpful. And then we have a problem of setting a threshold for what level and kind of behaviors we should say are concerning, to then stick the label of addiction or dependence or whatever word you happen to like on it. I think there's a more fundamental problem that we have even than that. And this is, again, me talking kind of as someone who has a background in behavioral science. Sometimes you would hear the phrase addiction, and then you'd also hear kind of in the same breath the word pseudo-addiction. And this is the idea that there are some people who are using opioids to get the reward from the opioids, the euphoria or the good feeling. And this is what we typically associate with addiction. On the other hand, you would sometimes say, no, in fact, what this person is experiencing is pseudo-addiction. It's their pain is inadequately treated, and they are engaging in these behaviors that are worrying us because they need their pain to be relieved. And therefore, these two things usually kind of argue for opposite responses. In one, you want to intensify the treatment. In the other, you say this treatment is causing harm and maybe we should stop it or control it more. The basic problem that I think we have, looking from outside, is that you really can't see inside anyone's head to figure out which of these things is going on. And as a behaviorist, one of the things that we know is that if a person or, any kind of reasonably complicated organism does a behavior and the consequences are positive, they tend to do more of that behavior and, refine it. And this process is called reinforcement. Behavior is controlled by its consequences. So if you get rewarded for a behavior, you tend to do more of it. But it's also true that if doing a behavior relieves you of some kind of suffering, you tend to do more of it as well. So it's not just reward, but it's relief that can reinforce behavior. That's called negative reinforcement. And the opioids do both. They can relieve pain, and they are rewards. And I don't think that there's any good reason to believe that they only do one thing at any one time in any one person. And in fact, there's a solid chance that they can do both at any time in various different combinations. So I think this kind of problem we have with addictions and pseudo-addiction and pain is that we keep trying to figure out the motive by which people are doing things, but motives can be complex, and the opioids can, they can reinforce behavior both of these ways. So all that being said, we do have some idea of what kind of behaviors that we think are worrisome. For example, if someone keeps accelerating their dose when it's not prescribed, if someone does keep losing prescriptions, all the way up to more severe things like overdosing. And you can count those in a population or in a clinic. And it does seem to be that what predicts those aberrant opioid use behaviors in pain populations is pretty similar to what predicts the onset of addiction in the general population. Being male, being younger, people who have a prior drug use disorder history, including, by the way, cigarettes, they seem to be a pretty significant risk factor for aberrant opioid use behaviors. But the more closely related someone's previously used drug is to the prescribed drug, the greater the risk. So if they had a problem with alcohol, they're at higher risk, but not as high a risk as if their the drug they had the problem with was oxycodone. And then psychiatric conditions, some of which are more significant than others. People with bipolar disorder seem to have a particularly high risk of addiction, but it's also a pretty, well, not rare, but uncommon condition, whereas things like major depression are very common. And so in terms of population risk, they're probably more important. And then those latter two, prior drug use disorder history and psychiatric condition, also having a family history of those two seems to be a risk factor for problems with opioids. And I want to talk a little bit about the psychiatric conditions, because this goes into another kind of paradox that we have in chronic pain management, which is that the people who have the most severe and refractory pain, who, there tends to be a stronger impetus to try more potent kinds of treatment for the pain, also tend to have other conditions along with the pain that are risk factors for that therapy going wrong. So the classic for this is major depressive disorder. And it's been clear for a very long time that people with chronic pain tend to have higher rates of depression. And it seems like the relationship kind of goes both ways. It looks like people who have higher levels of depressive symptoms or diagnosed depressive disorders are more likely to eventually develop a painful condition. It also appears to be that people who develop a painful condition are more likely to develop a depression thereafter. If you had to pick between which relationship was stronger, from my reading of the literature, it's more along the lines of pain seems to be a stronger precedent of depression than vice versa, but it does definitely go both ways, I think. Now, there is precious little study of the treatment, quite frankly, of chronic pain and sickle cell disease, and also not a tremendous amount of literature yet in some of the psychiatric complications or comorbidities of sickle cell disease. But there's a bit. This is another slide off of the Pisces study. I seem to be using them a lot. And I wanted to point out to table 2 over there on the left. So these were people who screened positive for an instrument that's supposed to detect people who are high risk for having a depressive disorder. That's not the same thing as what I would call major depression. And as a matter of fact, it probably includes at least 25% of people who I would say don't have major depression, but I'll have to get into the technicalities of screening for depression some other talk. But at any rate, the group who are called depressed here are probably, a lot of them are depressed and are at high risk of having a depression. And what you'll see is that the people who were scored as being depressed had a lot more days in pain, had more pain on those days, and were more distressed and had more interference from the pain. Another thing that I think is kind of fascinating about this is that they didn't seem to have more crises, at least in terms of the severity of the pain, but they were more distressed by the pain they had on crises. When they were at home, they tended to use more opioids, which kind of goes with having more days in pain, but they also got less relief from the opioids when they got them. And if you look over at table 4, this sort of association between depression and quality of life, there's a lot of these things that I would put in that rubric of function, social function, physical function. And you see that the people who were depressed had dramatically reduced quality of life. So we have this kind of complex of chronic pain, along with higher levels of depression symptoms, along with poor function, that you see playing out in the general chronic pain population, and does also seem to be sort of the same relationship among people with sickle cell disease. This is yet more complicated by the fact that it seems that folks who have depression are more likely to wind up on opioids, and maybe even through some way, in a way that's independent of their level of pain. So this is a graph from a study of a pain clinic, and there's 2 lines here. The blue line is people who did not have depression. And over on the left side on the axis is the chance that someone walked out basically with a prescription for opioids, and the bottom line is their reported pain severity. And you see that in the people who are not depressed, it's like a perfect line. If you have more pain, you're more likely to have a prescription for opioids. The red line at the top that looks flat is the people who had depression. And you see that pretty much regardless of their pain, they seem to be just as likely to be prescribed opioids as people whose pain was in the, severe range, the 7 to 10 range. If anybody is a statistics geek, as I sometimes am, you might notice that the error bars on that line are higher on the left. And that's because, as we've said before, people who have depression also tend to have more severe pain. So we have this very complicated situation that you see in the general chronic pain population that probably also is operating in people with sickle cell disease, which is that the more severe and refractory the pain, the more likely you have a depressive disorder at the least, probably also anxiety disorders. And that seems to have a way of getting people onto opioids, but also to increase the risk that people are going to get into trouble with the opioids. There actually was a study recently, I think it just came out a couple of weeks ago, that suggested that at a population level in the United States, maybe 15-ish% of people have some of these psychiatric diagnoses, but that 15 or so percent of people gets about half of the opioid prescription. So this seems to be bearing out in subpopulations and in the broader population. Now, this is a bad news, good news kind of thing, but I think one problem we have is the good news isn't necessarily talked about or implemented nearly as much as it probably should be. And I probably should just focus on this last bullet point on this slide, which is that if you have chronic pain and depression, it's true that the pain's going to be harder to treat. It's also true that the depression is going to be harder to treat than among people who don't have chronic pain. But if you happen to have both, and you're treated for the chronic pain, and then you are treated adequately for the depression, it tends to do wonders for the pain. And I've seen this repeatedly in my work in sort of multidisciplinary pain treatment program that we have at Hopkins, where people who have had all kinds of interventions and loads of medicines for pain that hasn't worked have dramatic improvements when their depression is finally recognized for what it is and is treated. This last bullet point summarizes the results from the SCAMP trial, which was a little over 5 years, but less than 10 years ago, which was an excellent, very well designed trial with a full 12 months of follow-up, which is a wonderful thing to see in the pain field, of people who had chronic pain and at least moderate levels of depressive symptoms. And what you saw was that the folks who were randomized to a more intensive, optimal treatment system for their depression, they definitely had better outcomes for their depression, nearly probably more than 50% improvement in depression remission rates, which is a pretty high bar. But they also had over double the level of clinically significant pain improvement, which is really quite remarkable when you think about how, generally speaking, people with depression and chronic pain are so hard to treat. So on the one hand, we have this problematic complex of chronic pain and depression, which makes it harder to treat the pain and puts people at higher risk depending on how their pain is treated. On the other hand, if we act upon that knowledge and treat people for the depression and recognize it, we seem to be able to do a whole lot of good. So these are the things that I think we have to know about and think about when we're talking about how to initiate chronic opioid therapy. We need to look at what's the chance it's going to work, what are the risks of the treatment, who's at higher risks for these risks, and what can we do to moderate that risk and try to make sure they get the best possible outcome from the treatment. And then we have the difficulty of, okay, we've placed our bets. We've decided that this is it's worth the risk and the possible benefit to put someone on chronic opioid therapy. Now we're going to do it, and then you and I, my patient, we have to watch for a while and see if it's working well enough and what kind of problems you're going to have from it to decide that we should keep doing this, increase it, decrease it, or if it's not working, to stop it. And there's some fog around who should stay on opioids as well. So I want to talk about that a little bit. So one thing that is a real bugaboo, I think, in the pain field and in thinking about chronic opioid therapy in general is this phenomenon of what's called opioid-induced hyperalgesia, which is that opioids, at least under some circumstances, not only have effects that suppress pain, but can increase pain. And this sounds nuts, but it definitely happens. And we've seen it both in animals and in humans, and I'll show a little bit about it later. So it appears that some of these adverse effects of the opioids might actually be higher at higher doses, while the therapeutic effects are less. So you see that in respiratory suppression and risk of overdose as well. So we have the difficulty that you have medicines that, in general, certainly for the short term, seem to suppress pain, but also are very complicated and have the ability to increase pain under some circumstances. It's very hard to figure out when that's happening or if it's happening, especially if people have a chronic disease that can progress and cause more pain on its own. And at the same time, if you keep going up on the doses, sometimes the therapeutic window, the sort of dose range you can use between what works and what causes serious problems, keeps shrinking. And I'll talk about that in a second or two. So this is kind of a busy, wonky, geeky slide, but when we're talking about this opioid-induced hyperalgesia, this is a slide from, I think, one of the animal studies that kind of pointed out how strange it is and how complex it is. And so I want to stick to the top left graph there. Now, this has been done with several different opioids. This particular one was done with heroin. It's been done with fentanyl. It's been done with morphine. These are all in mice and rats. This particular one's in rats. And what you see when you give opioids to mice and rats is that if you give it to them at a dose and frequency that doesn't cause tolerance. It's not all that frequent. What you'll see is shortly after they get the dose, they are insulated against pain. It's analgesic. But then there's a second phase after they get the dose and after that sort of pain suppressing effect fades, where they become hypersensitive to pain. So it's sort of biphasic. It goes up, it goes down. And you see this with people too, particularly with very short-acting opioids like remifentanil. Another thing that's very strange about this is as you keep treating the mice or the rats this way, that post-dose hyperalgesia, the sort of low period where after the analgesia fades, they become hypersensitive to pain, that gets steadily worse with repeated exposure. And that's that gray period where it says opiate treatment there. Now, if you stop the opioids, stop giving them these doses, that steadily improves until the mice or rats look normal. But even several weeks out, if you re-expose them to an opioid, that hyperalgesic phase is far more protracted than it was on their initial exposure. So they look normal, they have normal pain thresholds and all that stuff. But if they're ever re-exposed to the opioids, they become hypersensitive to pain shortly after the pain improvement effect fades. You can block this by altering another neurotransmitter system, and it's not been proven that we can do that in humans. But the upshot of all this seems to be that what happens is the opioids have two effects. One of them is they can suppress pain through usual opioid receptors. The other effect is they seem to change some other pro-pain transmission system in a way that sticks around for a very long time. And if the opioids are stopped, the mice seem to have a compensatory system. Their endogenous opioid system, the endorphin system, ramps up to compensate for that altered pro-pain system, and they look normal until you do something that alters their endorphin system, like either giving them an opioid antagonist or an opioid. And then you see that they are abnormal even weeks after they've been exposed to the opioids. So all this is a very wonky and geeky way of saying that opioids are really more complicated than just analgesics. They do a lot of things to the pain treatment system, to the pain processing system, that we don't understand all that well, and some of them seem to last quite a while. I also mentioned that the therapeutic effects may change relative to the adverse effects with increasing doses. This, again, is a bit of a geeky slide to make that point. This is a study of monkeys. We see this kind of thing in humans, but this is just kind of a nice graph. And the long and short of it is that the graph on the left is what happens when you give opioids and test for pain. And so as you, at baseline, that green line, you see that the monkeys get a pretty significant pain relief effect from morphine. After they've been dosed for a while, you get a reduced effect from the morphine, and then when the morphine is stopped and they have a little time to recover, they go back to their baseline. But you'll see that there's a big separation between when they're at zero dose, both at baseline and when it's been stopped, and when they're on higher doses. So you get more of a you get a stronger effect with higher doses from the morphine. The one on the right is a measure of respiratory suppression, which is sort of the most dangerous effect of opioids. It's how people die from overdose. And you see that the difference between high dose, low dose, and baseline is pretty thin. And what this kind of means in practice is that as people develop tolerance, and particularly as the dose keeps going up, the difference between the dose that relieves pain and the dose that can cause overdose steadily narrows, because the tolerance to the respiratory suppression effect doesn't go up as fast as the tolerance to the analgesic effect. Another place that you see this, which is less dangerous, but certainly quite unpleasant, is with constipation. There's remarkably little tolerance to the constipating effect of opioids, considering how much tolerance there can be to all kinds of other effects of opioids. And so, again, constipation can be a major limiting factor in opioid therapy. So we have this difficulty in continuing opioids, that if someone happens to get worse or doesn't seem to have a particularly great effect, particularly over the long run, it's hard to tell whether that's the disease or the medicines. And also, if you go up, you have kind of a steadily increasing risk that things are going to go wrong at higher doses. But then on the other side, if you eventually get to the point where you say, I just don't think that the risks of this are worth the level of benefit you're getting, or maybe you would actually be better off of the opioids. Declaring failure with opioids is a far more complicated thing than it is due to a lot of other medications. And that has to do with the fact that if you're tolerant to opioids and you reduce the opioid dose, you have withdrawal. And withdrawal from opioids, although it's not medically dangerous in general, although I think it might be open to some debate in sickle cell disease, where it can precipitate crises, and that's dangerous. In and of itself, it's not medically dangerous. It's really unpleasant. And people who, even quite determined folks who decide they really just want to be off of opioids, it's hard to get through a full opioid taper. This slide I'm showing you here is from a recent study that I think makes this point kind of indirectly, which is, this is a study in a pain journal of people who were referred to try to reduce or taper their opioid dose. And I think the results of the study are actually less interesting than how they did the study, because, and this certainly fits with my experience, they had close to 150 people who were referred for the study, and they only managed to enroll maybe 40-ish people, if that. A large number of people didn't, when they kind of went through the study protocol, and again, this was a really well-supported opioid taper with a physician assistant who was highly trained and provided a lot of sort of therapeutic support, but a lot of people didn't go for it. A lot of people who were referred, often by their doctor, I think, didn't want to taper at all, and some didn't want to do it at this place. But also, kind of buried in the methods, what you found out was that they had to move the goalposts of enrollment just to get even those, say, 40 people to start this study. And again, this is a study where you got a whole lot of support in trying to get through the taper. So they started out with a requirement for people having a 50% reduction in their dose. They dropped that requirement, and then they dropped the total baseline dose at enrollment requirement, so that you had to have only very modest goals and relatively low levels of opioid therapy to even enroll. So part of that also means that they didn't have enough power to detect very many effects. Another thing that I think was kind of interesting about this is that the people who did get this extra intervention, the supported taper with the trained physician assistant, they started out on lower doses, which is a little hard, makes things a little harder to figure out if it worked or not. They ended up on a lot lower doses of opioids, but a lot of people never got to zero. On the other hand, what happened was that they also didn't have worse pain, and they had less pain interference, and they felt more efficacy or ability to manage their own pain through the intervention. And these are the kinds of things you see with multidisciplinary pain care, that people will wind up either tapering off of their opioids or winding up on a lower dose of opioids, but be more functional and feel like they can manage their pain better. And sometimes, a fair amount of time in those kinds of settings, people also wind up doing that on no opioids. So as I said, declaring failure with opioids is not nearly as easy as it is with a lot of other medications where you can just stop it and there are no consequences, because declaring failure with opioids for people who are on chronic opioid therapy already means that you and your patient have to make a decision that you know for the short run is probably going to make them feel worse. And that's a hard sell for everybody involved. So, and then there's how do you decide when to do that? The easy one is if there's lack of an immediate clinical effect. If the opioids are not causing adequate pain relief at several weeks, they're probably not going to cause adequate pain relief, period. And so if it's just not working in the first few weeks, you can probably call it a day. Maybe you try one other opioid to see if someone has a slightly differential effect, but by and large, they probably don't improve with age. It gets more complicated when it gets into people who've been on it for the long run. Their pain is getting worse. You don't know if the disease is getting worse or if the opioids might be possibly making people worse. And even if that is the case, you can pretty much guarantee if someone goes through a taper, they're going to wind up feeling worse for some period of time. So if someone has worsened pain intensity or a worsened level of function, then you might consider declaring failure on opioids, but making that decision also comes with consequences. And it's hard for people to get through. And then, of course, there's the problem of these aberrant behaviors, and you have to decide what level of aberrant behaviors warrant someone coming off of opioids. Sometimes it's a no-brainer. If someone has overdosed on opioids or done something really, really outside the pale, then it's entirely too dangerous for them to stay on. But that's seldom the case. Usually it's something much more ambiguous, like someone accelerating their dose without consent of the doctor. And that's harder to figure out what to do with. And then even more complicated is if someone has a little bit of a response, but not much, and you're committing someone to being on a medication that causes all these side effects for a very long period of time for not much, but something. And then that has to be talked through with the patient. So declaring failure with opioids is a very complicated decision. So trying to sum up something that I think I have just made extremely complicated, because it is, and bring it back to the simple. Here, in very short, is what I think about chronic opioid therapy and how we should do it. I think they work overall reasonably well for chronic non-cancer pain in the short run. We don't have much evidence that anything else works as well or better than the opioids, though there are some things that do work besides opioids. We have a really hard time talking about and assessing behavioral risk for chronic opioids because we're kind of stuck with the idea of addicted versus non-addicted rather than something we can really agree on and identify. And it's simultaneously true that people who have the most severe and refractory chronic pain also have extra risk factors for these kind of bad behavioral outcomes, which makes it difficult to the people who, on the one hand, you might be most tempted to put on opioids, on the other hand, often have things that elevate their risk for opioids, which is a built-in paradox of dealing with it. Clinicians, by and large, outside of certain subspecialties, are pretty poorly prepared to manage either people who have problematic behaviors with opioids or for whom opioids don't work. And getting people through an opioid taper is something that a lot of clinicians really don't feel comfortable doing. And then we have a big picture problem, which is that the whole medical care system is very fractionated, and it heavily disincentivizes multidisciplinary pain care, where an entire team of physical therapists, occupational therapists, psychologists or psychiatrists, pain professionals, and perhaps subspecialists are all at a table, all speaking the same language and all talking about the same patient. That's very hard to organize, very hard to get paid for, and there are very few such systems left. Even though we know that this works better, makes people more functional, and often gets them by with less medicine. So to try to make it even more simple and commit myself, Here's who I think should be on chronic opioids. I think people who have chronic near daily pain, who in their and the doctor or other clinicians' reasonable belief, think that the level of pain intensity or reduction they could get from the opioids is worth the risk of the opioid therapy, given that they're going to have about a 1/3 chance of having that level of pain reduction. And then opioid therapy should be started with a full assessment of the patient, including risk factors for bad behavioral outcomes and a comprehensive plan to manage the painful condition. It's not enough to just treat the number. And, in the case of sickle cell disease, you got to have people in adequate treatment for their sickle cell disease as well, or their avascular necrosis, or. People who are using chronic opioid therapy should have a good working knowledge of the risks and an ability to assess for the risk factors for problems, including psychiatric conditions, and an ability to stratify people on those risks and closely monitor the people who have more chance of something going wrong. It should be started, I think, with a solid idea of what constitutes success and failure between both the clinician and the patient, so that everybody agrees if it doesn't get us to this point, then we're going to try something else. And if that doesn't work, then we're going to stop the opioids, we're going to try other things. And you should always be able to declare failure. And if you start a medication that you don't know how to stop, you could get into significant trouble. So you have to be able to give opioid therapy in a setting where you know how to be able to get people off opioid therapy safely. And I think that we should try to avoid high doses of opioids. Opinions have changed on what is high. Back when I was in medical school, you would often hear there is no such thing as a top dose of opioids. Now, if you look at the CDC guidelines in the context of the current opioid epidemic, 50 to 90 milligrams of morphine for very, very short term is what's recommended. I personally, my own threshold is 90 to 120 milligrams of morphine equivalents, which is where in epidemiologic studies, in my estimation, you start seeing an uptick in death rates when people are prescribed levels around that or higher. And so that's where my ears usually prick up and I start thinking, is this really working and is it worth the risk for the long run? But there's debate on what is a high dose. But I think you also have to have a threshold for yourself as to what is a high dose and a justification for going above it. And so I think that's what I've had to say. And again, this is sort of from the perspective of a doctor who has to wrestle with all these kinds of things. So I'm trying to give a snapshot of the way my head works when I'm approaching this to the best of my ability. And so I'd also be happy to hear from anybody else who has different thoughts. But I'll open it to questions from here.
Thank you, Dr. Carroll. Again, so if anyone has any questions, please utilize the chat box on your webinar. It should be in your top row here. I see we have one question. Someone was asking whether or not the slides will be available for the presentation after. So typically within about 2 weeks of the completion of the webinar, we open the slides up to the public via YouTube, and you can check our YouTube page, which is WEPSC on YouTube, and you can view that slide and any other previous slides that we've presented for webinars. Are there any questions regarding the presentation today? Again, you can put your questions in the chat box, which should be on the top of your screen. And if you're joining us by phone and don't have access to the chat box, you can email me at alatson@wepsicklecell.org. I want to thank Dr. Carroll for joining us today. We really appreciate all that you've had to contribute. And I guess we'll give it a minute or two to see if anyone has any questions. And if not, we'll close out. And again, the webinars will be available online via YouTube at WEP Sickle Cell. I'm sorry, at ALATSON. I'm sorry. For YouTube, it's WEPSC. For emails regarding the SiNERGe project or the William E. Proudford Sickle Cell Fund, you can email me directly. That address is also on your screen, alatson@wepsicklecell.org. Okay, so I guess we don't have any questions. I want to thank everyone for joining us today. Please feel free to email us if you have any ideas about particular webinars that you would like to see. We'll be happy to put those together. The webinars are open to the public, to the general public. So if you know anyone who might be interested, please refer them to us. And we look forward to you joining us for our next webinar. Thank you for joining us and have a great day.